This is a very interesting and exciting subject. Unfortunately, many cardiologists are not engaged in dealing with peripheral arterial diseases. But I hope that changes if you know that out of every 4 patients with coronary artery disease, you have 3 patients with peripheral arterial disease. And if you screen people above the age of 70, 1 in 3 is having peripheral arterial disease. And if you look into the first slide, the lower bar here, these are patients from the partner trial. This partner trial is different from the partner trial of TAVI. So this in partner trial, which was published 20 years ago, patients between the age of 50 and 70 years of age who are either having diabetes or smoking. 1 in 3 is having peripheral arterial disease. So it's a very common disorder. It's not surprising that it is common because atherosclerosis is common, but it is very surprising that we don't detect it frequently. But the reason will be coming. The risk factors are exactly the risk factors for coronary artery disease, but the relative importance of smoking and the diabetes mellitus, as if you look to the odds ratio, far exceeds the effect of hypertension, hypercholesterolemia, and other factors. Remember, chronic kidney disease, insulin resistance, and C-reactive protein are important risk factors, maybe more important than hypercholesterolemia and hypertension. Controlling hypertension in patients with peripheral arterial disease is intuitively expected to diminish the blood flow to the limbs. But on the long run, treatment of hypertension is of paramount importance in diminishing the risk not only of peripheral arterial disease and amputations, but as well of the commonly associated central arterial disease, coronary artery disease, and cerebrovascular accidents. So treatment of hypertension is very important in these patients. Now, this pie diagram is extremely important. If you look to the left side of the diagram, you will find that patients presenting with peripheral arterial disease, the 50% are totally asymptomatic. So unless you have a good examination of the peripheral pulses in these patients with the limbs exposed completely, you can very easily miss peripheral arterial disease with consequent disastrous outcome. At the same time, you have to realize that even palpating the peripheral pulse, which can be normal, doesn't exclude the possibility of peripheral arterial disease. Sometimes the collaterals are so dense and intense to the degree that you can feel the pulse as palpable as normal, and so you should be on the tip of your toes in taking a good history and identifying whether the patient is having symptoms or not. But still, one important limitation of taking the history is present here on the right side of the slide. 15% only of patients have typical claudication. So the fact that you don't have a claudication doesn't also exclude the possibility of peripheral arterial disease. About 1/3 of the patients they have atypical symptoms. يقول لك أنا لما بطلع على السلم رجليا مش شايلاني. يقول لك إن رجليا لما بطلع على السلم مش حاسس بيهم. You get too many atypical complaints. Sometimes you attribute this to senility. Sometimes you attribute it to unconditioning. But still, you have to realize that atypical claudication or atypical function limitation is one of the main presentations of peripheral arterial disease. Fortunately, only a small percentage, 1 to 2%, present by critical limb ischemia, and we mean by this the presence of severe rest pain or loss of tissue or gangrene or ischemic ulcer. So it's very important to realize that atypical presentation is very common in this group of patients. What happens to the natural history of peripheral arterial disease within 5 years? Within 5 years, there is change in limb mortality, but the more important thing is on the right side of the slide, which is the cardiovascular morbidity and mortality. So fortunately, 70 to 80% of patients with intermittent claudication, they still have stable claudication if left untreated. At the same time, 10 to 20% they get worsening of claudication with decrease in the walking distance and decrease in the time until the onset of claudication. 1 to 2% only develop progress to critical limb ischemia. But the money was on the right side of the slide, where you find that mortality is very high, 15 to 30% in 5-year follow-up. And most of these patients are due to most of these deaths are due to cardiovascular mortalities. Non-cardiovascular mortalities account for only quarter of these patients. Non-fatal cardiovascular events, including stroke and myocardial infarction, occur in 15 to 30%. The lower diagram in the slide shows the J-shaped curve of the ankle brachial index. As you see, the normal value is around 1 to 1.1, up to 1.3 or 1.4. There is a discrepancy in the literature of making the upper limit of normal 1.3 or 1.4, but I think that's okay. So if you have a decrease in the ankle brachial index, mortality increases, and if you have an increase in the ankle brachial index, even within the normal range, if you get an increase to 1.4 or above, then again the mortality increase. So this is a J-shaped curve, another J-shaped curve, in addition to that of hypertension. Now, if we look into the characteristic features of intermittent claudication, which is typical in only 15% of patients with peripheral arterial disease, it's a discomfort or cramping or aching sensation in the calf or the thigh or the buttock, depending on the site of obstruction. It occurs on exercise or on walking and gets relieved by rest and is reproducible. Unfortunately, this description is available only or is volunteered by the patient in a small percentage of cases. Many of these patients, they present with atypical claudication or they are totally asymptomatic, as I just mentioned. Now, it's important to differentiate this kind of leg discomfort from other potential causes of exertional and non-exertional leg discomfort. Peripheral neuropathy is very common. Many of the patients are on gabapentin or progabalin for peripheral neuropathy. There might be a disc disease, particularly in the lumbar or sacral area. Many of the patients above the age of 50, they have spinal canal stenosis, in which there is narrowing of the spinal canal and compression of the coda equina with different presentations. But these patients usually they get the manifestations of lumbar canal stenosis as limitation of walking and aching sensation when walking, but they disappear when they lean forward. If they stand, the pain or the paresthesias or the dysthesias continues with these patients, unlike what happens with standing in peripheral arterial disease. So if he walks exactly like patients with peripheral arterial disease, he gets the discomfort. If he stands, the discomfort doesn't go away, unlike peripheral arterial disease. Popliteal artery entrapment, this is usually encountered in patients with muscular constitution, with the medial head of the gastrocnemius compressing the popliteal artery. Remember, in the lower limbs, we have three arteries below the popliteal artery. We have 2 arteries above the popliteal artery, but the blood in the lower limb goes in a single artery in the common femoral and the popliteal. So they are very dangerous vessels. If they get occluded, then the blood flow to the distal vessels is completely compromised. So popliteal artery entrapment is one of the main complaints of that can be encountered in muscular or athletic persons due to compression of the popliteal artery by the medial head of the gastrocnemius. Sometimes it needs surgical correction. Arthritis is common, muscle weakness and tightness with injury is common. Venous insufficiency is important. Patients with having damaged valve because of previous deep vein thrombosis, they get damage of the valve, increased the venous pressure, so the outflow from the arterial tree gets compromised. And as a result of that, they get venous claudication, and this venous claudication can be associated with other manifestations of venous hypertension, like the lipodermatosclerosis, pigmentation over the medial malleolus, sometimes ulcerations as well. So these are the important differential diagnosis which has to be taken in consideration in analyzing the complaint and the physical findings in patients with peripheral arterial disease. Some patients, they say, I was all right, but the pain has been very, very, very severe today only. And these are the patients who present with the several P's: pulselessness, pallor, poikilothermia or coldness, paralysis or paresthesias, etc. This is the result of acute occlusion of the lower limb arteries as a result of atheroembolism. So whether it's the outcome of the secondary to atrial fibrillation or abdominal aortic aneurysm, or secondary to bacterial endocarditis, or less commonly due to arterial or aortic dissection. Sometimes you get a small aortic aneurysm below the threshold, small aortic aneurysm, let us say 3.4 or 4.1, is producing intimal thrombosis, which are being embolizing all the time to the lower limb. And under these circumstances, some of these patients respond to statins, some respond to antiplatelet drugs, some do not respond. So under these circumstances, you are forced to take away this abdominal aortic aneurysm to prevent embolization to the distal vessels in the lower limb, despite being subthreshold. Acute plaque rupture with an abscess formation resulting in thrombosis overlying the acute plaque rupture can also result in acute stent thrombosis because of hemorrhage or acute thrombosis in these vessels. So these are the acute limb ischemia which is encountered occasionally. It's very important to realize the anatomy of the lower limb vasculature. We are not working with it frequently, but if you look from the left side of the diagram, here is the renal arteries. Above the renal arteries, you have the superior mesenteric, and above it, the celiac axis, and then below it, you have the inferior mesenteric artery. Then there is bifurcation into the two common iliacs. The common iliac gives an internal iliac artery and then continues as the common femoral below the inguinal ligament. And the common femoral arborizes into the superficial femoral artery, which is not superficial, it's covered by the sartorius muscle. And the lateral branch is the profunda artery or the deep femoral artery. The deep femoral artery is a very tiny, delicate vessel, and usually we don't carry out interventions on the profunda artery because usually it lacerates and dissects. And then the superficial femoral artery, which is a very long artery, one of the longest in the body, goes through the adductor canal as it becomes the popliteal artery, and the popliteal artery gives the anterior tibial artery, which is a lateral branch. The anterior tibial artery continues anteriorly and becomes the dorsalis pedis. And the other bifurcation, the other limb of the bifurcation of the popliteal artery is the perineal tibio-perineal trunk. It bifurcates into the perineal artery, which goes down the posterior cuff, and the posterior tibial artery, which goes all the way down around the medial malleolus and continues carrying the same name, the posterior tibial artery in the foot. So as you see here, we have two lateral branches here. This lateral branch is the profunda artery in the thigh and the anterior tibial artery in the leg. And as I told you, we have three vessels right here. We have two vessels right here, but only one vessel, the common femoral, and the popliteal artery through which the blood. If we have an acute limb ischemia, the aim of any intervention, be it procedural cardiac catheterization or peripheral vascular catheterization or surgical, is to ensure the presence of a pulsatile one single line of flow right from the common femoral artery or the external iliac artery down to the dominant vessel which supplies the soul. So if you have a critical limb ischemia, you have to have one vessel at least among these three vessels and one vessel at least among these two vessels, but always the popliteal and the common femoral should be patent. Now, if you have an aortic or iliac disease, then you will feel the claudication in the buttocks or and the cuffs. If they have a femoral or popliteal artery occlusion or stenosis, you have claudication in the cuff. Usually, you have one joint between the site of claudication and the site of occlusion of the vessel. When critical limb ischemia or severe ischemia develops, then usually you find the pallor, which can be elicited by elevating the lower limb at 60 degrees and waiting for 1 or 2 minutes. Usually the rubor disappears and pallor occurs under normal circumstances after 1 minute. In severe ischemia, the pallor develops in less than 30 seconds. If you dangle the leg down, then the rubor, which is against the pallor, the rubor appears in less than 30 seconds in the normal circumstances and in more than 1 minute if you have severe ischemia. Patients with peripheral arterial disease know that, so they dangle their leg while they are sleeping, and that's why with severe ischemia you get edema of the lower limbs, not because of a concomitant venous insufficiency, but because of dangling the leg to help the gravity supply the lower limbs with sufficient blood flow. You get hair loss in the lower limbs, you get dependent edema, we explained it, and sometimes you get ulcers. And of the 3 types of ulcers which we encounter were linked, the arterial ulcer has a pale base, irregular border, and is usually located in the peripheral part of the limb, tips of the toes or the heel of the foot. This stands in contradistinction to the venous ulcer, which is usually located on the medial malleolus and is associated with pigmentation, hemosiderosis, and lipodermatosclerosis with thickening of the skin, and is different from the nervous ulcer, which occurs in peripheral neuritis and other neurologic disorders, which is present usually at the sole of the foot and frequently is painless and is infected. One of the important findings that clinches the diagnosis of peripheral arterial diseases, particularly when the patient is having a strong suspicion of the condition and is asymptomatic at the present time, is the ankle brachial index. And the ankle brachial index is to divide the ankle pressure, the higher of the 2 ankle pressures in either limb. So if you take, for example, the left leg here, you measure the pressure in the dorsalis pedis by the Doppler probe and the posterior tibial. You take the upper one, the higher one, here in this patient's 120, and you measure the blood pressure in the 2 arms and you take the higher one. So if you in this cartoon, you have here the blood pressure on the right side, 150 systolic, 160 systolic. So you divide 120 by 160, and this is 0.75. If you go to the right side of this patient, then you will take the higher of the dorsalis pedis and the posterior tibial. So under these circumstances, it is 80, and they divide it again by the higher pressure in the 2 arms, which is 160. So 80 divided by 160 is 0.5. So this is an important simple test. Usually we don't carry it out. We send it to the vascular laboratory where Doppler is available. I used to do it previously by the cuff and the stethoscope, cuff of the sphygmomanometer and the stethoscope, but it's not as accurate as when you carry it out in the vascular lab by the Doppler. Now, if you are having a ratio between 1 and 1.4 or 1.3 in certain guidelines, it is considered normal. If it's less than 0.91 between 0.91 to 0.99, it's borderline abnormal. If it's less than 0.9, it's definitely abnormal. If it's less than 0.5, then it indicates critical limb ischemia. If it exceeds 1.4 or 1.3, it means that the vessel is uncompressible. This usually occurs in diabetics, occurs as well in patients with renal failure. Under these circumstances, you either go to pulse volume recording or you will get not the ankle breaker, but the toe brachial index. And the cutoff value under this circumstances is 0.6 to 0.7. If you are in the borderline zone, then you exercise the patient. There are several protocols by which we exercise the patient. One common protocol is to fix the speed at 2 miles per hour and increase the elevation by 2% every 2 minutes for 5 minutes. Under these circumstances, as a result of exercise, the blood pressure rises very much in the upper limbs, doesn't rise as much in the lower limbs. So the ABI decreases with exercise if there is a significant stenosis in the vessels of the lower limb. So that's the important things that you must know about the ankle brachial index. Now, according to the guidelines, these are the class 1 indication with level of evidence B for undergoing ankle brachial index testing. Patients with exertional leg symptoms, patients with non-healing ulcer, and any patient above the age of 65, a very aggressive indication, but this is the guidelines, or patients between the age of 50 and 65 with a history of smoking and diabetes mellitus. So this is important. It's a very frequently neglected method of evaluating patients with peripheral arterial disease. Now we use it to do segmental pressure measurements, pulse volume measurements, plethysmography, but these are almost outdated after the establishment of the duplex ultrasound, which combines grayscaling as well as color Doppler and color coding and the Doppler evaluation. So if you look here on the right side, there is the head of the patient. On the left side, the feet of the patient. This is the popliteal artery. This is the normal laminar flow. It has a red orange hue. And if you put your probe, you'll find the normal Doppler depiction of the blood flow with an initial systolic forward flow, and then an early diastolic reverse flow, and a third pump here, which is a late diastolic flow. This corresponds to the forward flow. This is the reflected wave from the periphery or the bifurcation or the peripheral vascular resistance, and this is the result of the recoil of the aorta. So as you see here, you have a nice triphasic waveform. This triphasic waveform connotes that there is no significant obstruction in these patients. So the combination of the gray scale as well as the color coding and the pulse Doppler is the most important non-invasive evaluation of patients with peripheral vascular disease. Whenever you have anything abnormal, then you get the changes in the velocity. If the peak systolic velocity exceeds something like 125 centimeters per second, that's a significant obstruction. Equally important is an increase in the ratio of the distal to the proximal peak systolic velocities. If it is 2.1, this is significant, and this means that there is 50% or more obstruction. If it's 3 to 1, it's 75% obstruction of the vessel. You get also elevation. You get as well. You get also as well elevation of the baseline diastolic Doppler spectrum. So you get increase at the end of the. So you get an increase in the end diastolic velocity, particularly if the peripheral vascular resistance is in the territory of a low resistance vessel like the internal carotid artery. It gets more than 40 centimeters per second. And you get aliasing or mosaic appearance in the Doppler flow. If you look here, there is a compression in this area with little aliasing. And if you look into the gray scale here, you will find that there is some lines here indicating the presence of an atherosclerotic plaque obstructing the vessel. At the same time, as you see in this here, so you get reduction in the diameter of the vessel. So these 5 abnormalities are very indicative of the presence of an abnormal obstruction, a hemodynamically significant stenosis in these patients. We have as well the CTE and the MRI, so they are available in most hospitals now, at least in the teaching hospitals. We are more, as cardiologists, we are more accustomed to the CTE. So if you like, in the left side of the slide here, You will see the anatomy which we have just described with the superficial femoral. The superficial femoral, the popliteal. Here on the left side, there are the three lower leg vessels. The three lower leg vessels. On the right side, there is obstruction of the peroneal, so you get only two vessels in the leg. On the right side, you have an axial display of the same phenomena. This is the tibia, this is the fibula, and you see the three vessels here, the anterior tibial, the peroneal, and the posterior tibial. But you miss here the peroneal artery. So the CT is really helpful in underscoring the vascular supply to the lower limbs. Same applies to the MRI. You get black blood pictures. We are not very much accustomed to seeing these pictures with the black lines here, but it provides almost the same information. At the same time, if you have, it depends on your institution. If you have a well-versed CTA or an MRI, you can choose either in addition to the duplex scanning. Now, what is the guidelines in management of patients with definite claudication? Number one is risk factor modification and the smoking cessation. This is actually number 1, 2, and 3. Number 2 is initiation of anti-atherosclerotic treatment, including aspirin and statin, when they are medically indicated and no contraindication to aspirin. Statin, actually, because of its pleiotropic effect, it doesn't only decrease serum cholesterol, but it enhances the endothelial function and increases the walking distance. Then the most important thing after risk factor modification and the smoking cessation is exercise program. You get a supervised exercise program of 30 to 45-minute sessions, 3 or more times per week for 12 weeks. It should be a supervised exercise program. If the patient says, okay, I will do it on my own, that's unreliable. So the value of unsupervised exercise program is not well established. So it's very important that the patient should have some rigorous form of exercise training, very rigorous and very disciplined, and for sufficient time. This can result in increase of the exercise capacity of the patient by 180%. So it's a very important thing. The guidelines also tells you about the antiplatelet therapy. Aspirin in small doses is safe and effective, or clopidogrel. We usually don't give dual antiplatelet therapy in these patients unless there is another indication. And usually they are associated with diminished incidence of myocardial infarction, stroke, vascular death, even in asymptomatic individuals with an ankle breaker index that's abnormal. Now this shows the slide taken from the heart protection slide back in 2002. And as you see in red here, the effect of statin therapy in peripheral arterial disease, there is 20%. There is 20% decrease in cardiovascular events in patients with peripheral arterial disease if they are taking statin in the appropriate way. So statin improves the walking distance, improves vascular endothelium, improves the outcome in terms of myocardial infarction, stroke, or amputation. What about the different vasodilators? Cilistazole, this is an phosphodiesterase 3 inhibitor. It improves the symptoms. It increases the walking distance taken for 3 to 6 months by about 70%. It's indicated in patients with lifestyle-limiting claudication, but the important caveat is that it's contraindicated in patients with heart failure. There is some interaction between platel, which is cilostazole, and diltiazem, as well as omeprazole. So that should be taken in consideration when you prescribe this medication. It's actually outperforming Trintal or pentoxaphidine, which is an aminoxanthin derivative, and was used in the past for the same reason. But now it has been completely replaced by platel or xylostazole. By the way, xylostazole is an efficient anti-platelet drug, and in the Far East it is used instead of Plavix. So it can be combined with aspirin as an anti-platelet drug, but this is not usually in the Western guidelines. Here is a question: a 54-year-old man referred for evaluation of angina, which occurred halfway through his usual 8-mile run. That's marvelous. During the performance of a coronary arteriogram, a calcified right common iliac artery plaque was noticed on fluoroscopy. A hand injection suggests a stenosis severity of 65% over a length of 2.5 centimeter, and there is a 5 millimeters of mercury pressure gradient across this stenosis. The question is, according to the peripheral arterial disease guideline, which of the following is a class 1 recommendation for this lesion? Endovascular intervention with drug-eluting stents, or endovascular intervention with bare metal stents, or giving this patient xylostazole, or giving him statin? The answer is D, giving him statin. As you see, this patient is doing a lot of work. He doesn't give full indication except after he runs 4 miles. And it's surprising that the patient underwent coronary angiogram. Probably it wasn't indicated. And so there is no indication for the intervention in these patients. Also, there is no indication for xylostazole, which is also given for incapacitating claudication. So what do the guidelines say about class 1 indication for revascularization? The indication is persistent, life-limiting claudication despite maximal medical therapy, or critical limb ischemia, which manifests by rest pain, non-healing ulcer, or gangrene. So as you see, the indication for revascularization in the peripheral arterial disease is very, very conservative. You don't resort to revascularization except when the patient is really incapacitated by his peripheral arterial disease. So stopping smoking, lifestyle modification, exercise program are the mainstays of treatment in these patients. So what do we do for patients with aortoiliac occlusive disease, which is the inflow to the lower limb? As you see here, in a patient with bilateral aortoiliac occlusive disease, this is an ideal patient for stenting. Usually when we have a disease in the lower aorta, which is Loriche syndrome, we either do it surgically, or more commonly nowadays we do it by kissing stenting. And then for the iliac arteries, here, stenting these patients by balloon dilatable stents is the technique of choice, of course. Balloon dilatable stents because they are more sturdy with more radial strength, not by the self-expanding stent. So there is a high procedural success for these patients. This is an indication of the transatlantic intersociety classification, and A is a short lesion less than 2.5 centimeter. So this is the outcome of these patients is excellent with long-term patency. Why there is long-term patency? Because this is a big vessel, so it needs a big stent, and this means a big flow. So if you have a big vessel with big stent deployed in it, and you ensure a big flow, the patency is very acceptable. If you have signs of poor outcome, like long segment of occlusion, or multifocal stenosis, or eccentric calcification, or peripheral runoff, then you ought to think in other lines of treatment. Now, the usual thing, if we go down to the lower limbs, if you go down to the external iliac is carrying the same labels for treatment by balloon dilatable stent. If you go to the common femoral artery, there is no stenting in the common femoral artery. Treatment is surgical by local anesthesia. It's a superficial vessel. If you go down into the superficial femoral artery, then the treatment of choice is usually drug-eluting balloon. You don't resort to stenting in the superficial femoral artery except as a bailout, or if you have a long segment of stenosis exceeding 10 centimeters. If you go to the popliteal, again, the popliteal, we don't like to stent it because it's against a joint. So again, it's a drug-eluting balloon. Infrapopliteal vessels, usually we don't stent them except as a bailout. Usually we use the drug-eluting balloon for these patients. And usually we aim at dilating only one of them. So by this way, you can create a pulsatile line of flow going from the common iliac artery down to the arch vessel, the sole arch vessels, and that ensures healing ulcers or blocking the occurrence of severe pain of critical limb ischemia. So this is in a nutshell how we proceed with the treatment, the intervention and treatment of patients with the lower limb. And this shows the superficial femoral artery in the left leg of these patients with multi-lesional, multi-segmental affection. This is the usual picture which you encounter in diabetic patients or in patients with chronic kidney disease. And as I told you, usually we proceed to dilate these patients with a drug-eluting balloon and don't stent them except when needed as a bailout. This is the profunda artery. We don't touch it usually by intervention, being a small vessel, very, very delicate and very prone to dissection and occlusion. And as you see, the result here is very, very well acceptable with the superficial femoral artery dilated in an appropriate way. Now, this shows you what is the outcome over the years. As you go towards the central circulation, the patency rate increases. So if you are dealing with iliac percutaneous transluminal angioplasty, as you go to the iliac, or whether you are doing a PTA or deploying a stent, the outcome is very, very good. Within 5 years, you have more than 75 or 85 even patency rate. But as you go down away from the central circulation, the patency rate starts to decrease. So if you go to the infrapopliteal vessels, as you see here, we don't use stents usually. Usually you get an occlusion or a restenosis in the range of 20-25% over 1 year, not 5 years. So the central theme of restenosis or recurrence of the same situation, the stenotic situation, is that as you move towards the central circulation, the patency rate is higher. As you move towards the peripheral circulation, the patency rate is definitely lower. So taking that in consideration, let us take the question 2. The expected 5-year patency rate for aortoiliac or aortobifemoral bypass grafts is 90 or 70 or 60 or 50%. The obvious answer, taking the rule that I just alluded to a while ago, is that as you move towards the central circulation, the expected 5-year patency will be high. So the appropriate answer for this type of grafts is usually 90% in 5 years. So that's very rewarding. Although these kind of operations are very rarely done now, taking in consideration that most of the peripheral vascular surgeons became expert in peripheral vascular intervention. And this is a table which shows the patency rate over and the mortality rate over time. And as you see again, if you are towards the central circulation, you have an aorta. You have aortofemoral bypass or aortoiliac bypass. The patency rate is above 85. And if you go down towards the peripheral circulation, the patency rate decreases markedly. Now, if you have a hostile abdomen and you cannot carry femoral bypasses, aortofemoral or aortoiliac bypasses because of a hostile abdomen, because of previous surgery with adhesions or previous irradiation, then under this circumstance or an infection, Then under these circumstances, you do an extra anatomical bypass like axillofemoral or axillobifemoral. Again, these are becoming rare procedures, very rarely resorted to by the surgeons. What about the popliteal aneurysm? I called your attention previously that the popliteal artery and the common femoral artery are solitary artery in their territory, and they are very important. Sometimes you get a popliteal aneurysm. If you remember that a popliteal aneurysms occur in 15% of patients with aortic aneurysm. So if you feel the popliteal artery clearly, usually you have to spend some time finding out the popliteal artery. If you feel it clearly and if you feel it bounding, then you have to have an ultrasound. If there is an aneurysm, make sure that there is no other aneurysm in the contralateral side or in the popliteal artery and in the aorta and maybe in the cerebral vessels as well. The popliteal aneurysm can be a source of peripheral embolizations and should be fixed. So surgery is indicated for aneurysms more than 2 centimeters. This is a class 1 indication. Sometimes when you are dealing with elderly patients, you image the aorta, you find an idiopathic dilatation of the aortic root, 3.4 or 4.1, something like that. And then you look into the subclavian, again, it is big. You look into the carotid, it is big. Even the pulmonary artery is big. This is called arteriomegaly. If you have this arteriomegaly, look for a popliteal aneurysm because of the common association between generalized arteriomegaly and popliteal aneurysm. Under these circumstances, if you find it, then make an ultrasound more than 2 centimeters. It needs to be fixed. Sometimes you get a thrombosis in the popliteal artery, and this needs as well catheter-directed thrombolysis. Third question, a 70-year-old woman underwent PCI via the right femoral artery on rounds following the next morning. In the next morning, she denies pain because she took intravenous analgesia. For which of the following bedside findings would duplex ultrasound most likely demonstrate a pseudo or a false aneurysm? If the patient gets back pain and flat ecchymosis with hypotension, or if the patient is having painful pulsatile mass with a bruit over the catheterization access site, or there is a prominent thrill over the femoral artery with continuous bruit, or pulsiousness in the ipsilateral foot. Now let us take them one by one. After cardiac catheterization, the patient gets back pain, flank ecchymosis, and hypotension. That's retroperitoneal hematoma. It's very important to be cognizant of that and take the necessary steps to repairing it. If you get number 3, prominent thrill over the femoral artery with a continuous bruit, that's arteriovenous fistula. It needs to be tackled either non-invasively if it's small by compression with a probe, or it's treated surgically. And number 2 is the correct answer, painful pulsatile mass with a bruit over the catheterization site. Usually we compress it by the probe of the ultrasonic probe, but more frequently by injection of thrombin into the neck of the aneurysm and the compression as well. It's very painful, so the patient should take intravenous analgesia and local anesthesia at the same time to tolerate the compression for something like 20 to 30 minutes. So it's a common complication that should not be overlooked. Now we move to the renal artery, and then we will move to the mesenteric arteries, then we move up to the upper limb arteries, and we end by the carotid circulation with some comments on transient ischemic attacks. When should we think of renal artery disease? Hypertension of recent onset, hypertension at young age less than 30 when we think of fibromuscular dysplasia, or above the age of 55 when you think of atherosclerotic renal artery stenosis, or accelerated resistant or malignant hypertension, or the patient has been exposed to ACE inhibitor or ARBs and we developed azotemia as a result of that, or he gets pulmonary edema out of the blue, flash pulmonary edema, the patient is having hypertension, pulmonary edema, although we know that pulmonary edema is frequently associated with hypertension, but you know from the history that the patient has been having controlled blood pressure, suddenly the blood pressure lost control, and as a result of that he gets flash pulmonary edema, or there is discrepancy between the two kidney sizes of 1 centimeter or more. So we alluded to that in the discussion of hypertension. If you put the ultrasound into play, then these parameters almost confirm the diagnosis. If the peak systolic velocity more than 200 centimeters per second, if there is elevation of the diastolic Doppler signals from the baseline, as you see here, so the end diastolic velocity is more than 150 centimeters per second, or if there is a post-stenotic turbulence into the renal artery, although this is frequently masked by gases in the abdomen. It's very important that you realize these findings, and it's also equally important to realize that unilateral renal artery stenosis has a completely different pathophysiology from bilateral renal artery stenosis. When you get a unilateral renal artery stenosis, the renin, which rises from the juxtapulmonary apparatus, elevates the blood pressure and results in pressure natriuresis in the other kidney. So the patient is not hypervolemic under these circumstances, and hypertension is driven essentially by renin, and the treatment of choice will be anti-renin or RAS inhibitors. On the other hand, in bilateral renal artery stenosis, you get elevation of the blood pressure because of renin secretion, and as a result of that, you get salt and water retention, and salt and water retention cannot be disposed of because the other kidney is also stenosed as well, so there is no pressure natriuresis under these circumstances, and the pressure the high blood pressure in these circumstances is volume dependent, and the treatment of choice here will be diuretics and vasodilators rather than RAS inhibitors. As a matter of fact, RAS inhibitors is absolutely contraindicated in bilateral renal artery stenosis. So it's very important to know the mechanism and the way you are thinking about the treatment of these patients. Now, CT can also give you an idea about what's going on, particularly calcification of the aorta. In this patient, you have a stent located in an atherosclerotic proximal renal artery stenosis on the right side. So calcification can be very well displayed here. Now, we know that the treatment is medical treatment in the large majority of cases, and here is the guidelines. Class 1 indication is only one thing: renal artery stenosis with unexplained flash pulmonary edema. Any other indication is just a relative indication. If you are dealing with resistant hypertension, malignant hypertension, unexplained unilateral small kidney, or progressive renal disease in bilateral renal artery stenosis, or stenosis of a solitary kidney. The commonest solitary kidney, of course, is the renal transplant. And occasionally, if you have renal artery stenosis with unstable angina, patient with blood pressure out of control, and results in instability of the angina. So in all trials, the primary endpoint was not met. The only class 1 indication in patients with renal artery stenosis for intervention is class 1 indication is renal artery stenosis with flash pulmonary edema. Question: 48-year-old woman suffered type B aortic dissection. She has been having hypertension since her late teens. Angiography is shown. What's the diagnosis? Is it dissection of the left renal artery, or renal artery fibromuscular dysplasia, or a polyarteritis nodosa, or atherosclerotic renal artery? It's an easy question. As you see the close-up here, there is a string of beads appearance here, which is very characteristic of fibromuscular dysplasia. Remember, fibromuscular dysplasia can be medial, adventitial, and endothelial. And it's the medial fibromuscular dysplasia which will produce this picture. Any fibromuscular dysplasia otherwise can produce just smooth narrowing, but still in the distal third of the renal artery. The important difference between fibromuscular dysplasia with its various types and atherosclerotic renal artery stenosis is that atherosclerotic renal artery stenosis is in the proximal renal artery. The atherosclerotic plaques moves from the aorta into the central part of the renal artery. In contradistinction to that, the peripheral renal artery is the location of the fibromuscular dysplasia. So the treatment is different. For fibromuscular dysplasia, it's just the balloon angioplasty. You don't resort to stenting under these circumstances except as a bailout measure. On the other hand, if medical treatment fails or there is flash pulmonary edema, you stent the proximal pulmonary artery. We know that stenting here will result in peripheral distal embolizations, and these distal embolizations is the reason why stenting is not a priority in treating the pulmonary renal atherosclerotic renal artery stenosis, in addition to the toxic effect of the dye. So we move into visceral arterial disease. Visceral arterial disease, we know that the viscera are supplied essentially by the celiac axis, the superior mesenteric and the inferior mesenteric, and there is dense collaterals, particularly the artery of Dramamond and the arc of Rayone. These are important connections between the superior mesenteric branches and the inferior mesenteric branches, the gastroduodenal branches, which are branches of the celiac axis. You might get an acute mesenteric ischemia or a chronic mesenteric ischemia. Acute mesenteric ischemia presents by abdominal pain, almost without physical findings on examination. So the abdomen is lax, there is no rigidity, there is no rebound tenderness, there is nothing. You also remember that abdominal pain with negative physical findings, in addition to pancreatitis, think about acute mesenteric ischemia. Of course, you don't need to overdiagnose the situation because this is usually a fatal condition in patients with advanced atherosclerosis. So the risk factors are usually old age, atrial fibrillation, and low cardiac output. In low cardiac output state, you get venous thrombosis as well as arterial thrombosis. The outcome is miserable with 77 rate of mortality if there is arterial thrombosis, 54 mortality rate of arterial embolism, and 73% with non-occlusive ischemia as a result of hypotension and shock, and 32% of venous thrombosis, which usually the result of sepsis in the abdomen, hypercoagulable state, portal hypertension, and the use of drugs. The usual treatment under these circumstances is rapid, quick intervention, either by thrombolysis or thrombus suctioning. But if there is evidence that a delay has occurred, then surgical exploration is indicated, looking at the bowel, and if there is a dusky bowel, then a resection of the necrotic bowel and continuation of the intestinal continuity. And at the same time, you need for a relook again to make sure that there is no advancing gangrene after 24 to 48 hours. In the chronic situation, you have to have obstruction of 2 out of the 3 vessels at least, if not the 3 vessels. So in chronic mesenteric ischemia, as a result of combination of SMA and IMA or celiac axis multi-vessel disease because of advanced atherosclerosis, you get postprandial abdominal discomfort, postprandial abdominal angina. These patients are having cetophobia. Cetophobia means that there is aversion or fear of eating because eating is producing abdominal pain, and as a result of the cetophobia, they get weight loss. These are patients are elderly, they have advanced atherosclerotic cardiovascular disease. The diagnosis should be suspected in this kind of patients, particularly if they have postprandial angina. And as I told you, the treatment is revascularization and usually is done by cardiac catheterization rather than surgery. Now, if we move to the upper limb, we have a wider variety of causes for upper limb peripheral arterial disease, but still at the top of the list is atherosclerosis, which involves the proximal vessels of the upper limb. but particularly the subclavian artery. Patients who are having internal mammary artery and then they develop angina after that, the problem can be in the conduit, which is very rare. It can be in the native vessels, which is commoner, but it can be in the proximal subclavian. So if you find a difference in the blood pressure of 15 centimeters or more, 15 millimeters of mercury or more between the two limbs, be alerted to subclavian stenosis. Do an ultrasound, confirm it by cardiac catheterization. Make sure that the problem is not in the subclavian artery, otherwise you can miss the diagnosis and the patient gets resistant angina. Vasculitis is an important cause of upper limb ischemia. The two important conditions, very similar to each other with very minor differences, is Takayasu, which is common in younger women and involves the aortic arch vessels, and the giant cell arteritis, which is common again in women, but elderly age associated with polymyalgia rheumatica and temporal arteritis. And as you know, the temporal arteritis is patchy, so if you take a biopsy, that should be a long biopsy. But I think the days of biopsy is gone, and the ultrasound can depict what's happening with the very famous halo sign. The halo sign is you get inflammation with a halo around a thrombosed vessel, which is the superficial temporal artery. You can get compression from the thoracic outlet syndrome, which can present either as a neurogenic syndrome, compressing the lower cords of the brachial plexus, or a venous syndrome, compressing the subclavian vein, or an arterial syndrome, and this arterial syndrome compressing the subclavian. There are a lot of maneuvers that can help with the diagnosis. The Addison maneuver is less sensitive. The Addison maneuver is just elevating the abducting the upper limb like that, and then externally rotating the upper limb, and at the same time bracing the shoulder backward, looking to the other side, and taking a deep breath. Under these circumstances, if there is a thoracic outlet obstruction, then you get loss of the pulse. But more importantly and more sensibly is the east. East is elevation, stress of the upper limb. And this, you put your hands in the surrender position like that. This is the surrender position. You open and close the fits for 3 minutes. And as a result of that, you get reproduction of the symptoms of the thoracic outlet. So these maneuvers are very well-known maneuvers for proving the diagnosis of the thoracic outlet syndrome. And as I said, it can present as a neurogenic syndrome, which is the commonest, and less commonly venous syndrome, and least commonly arterial syndrome. You might get embolic cause for upper limb peripheral arterial disease or vascular malformation, but more frequently we see now is the arteriovenous fistula created for dialysis. So the arteriovenous fistula created for dialysis can be a large fistula that results in high cardiac output, heart failure with cardiac enlargement, jugular venous distension, as well as elevation of the cardiac output. Under these circumstances, you have to decrease, constrict the fistula a little bit. Or on the other hand, the outlet of the fistula might be compromised, and the blood flow to the distal forearm is stolen, and as a result of that, you get pain and discoloration of the fingers. Under this circumstances, the outlet of the fistula should be repaired. So the arteriovenous fistula created for hemodialysis can create problems either on the higher side with heart failure developing, or on the lower side with impaired blood flow distal to the forearm. So these are important causes, not comprehensive, but important causes. If you look here, this is the subclavian artery, which is almost always involved in Takayasu, almost always. And again, it can be involved in giant cell arteritis, and as I told you, the difference between it's the same granulomatous arteritis affecting the large vessels. These are the two most important large vessel vasculitis. They are very similar to each other. They are characterized by inflammation of the intima, media, and adventitia with thrombosis of the vessels, giant cell, and the granulomatous formation. And the subclavian is frequently involved in both, particularly in Takayasu. And the treatment is usually surgical. We tried previously to dilate the takayasu subclavian. It's hell. It's very tough fibrous tissue you cannot overcome easily. Now this is a table which compares the different forms of vasculitis, including the large and medium vessel. It lacks the microvascular vasculitis. Here is the giant cell arteritis, Takayasu arteritis, polyarteritis nodosa, Kawasaki disease, and the Berger's disease. By far, the commonest cause of vasculitis is Kawasaki. Giant cell arteritis involves the central vessel, the thoracic aorta, the abdominal aorta, the carotid arteries, and the upper limb arteries. Same applies to Takayasu, very similar, but Takayasu in addition can affect the pulmonary arteries as well. As I said, these are two large vessel vasculitis with granulomatous formation, giant cell infiltration. The giant cell is just amalgamated monocytes. And polyarteritis nodosa is a medium vessel vasculitis. It has a propensity to affect the mesenteric arteries and the renal arteries. Usually we diagnose it by biopsy if there is a skin lesion that's available. Otherwise, angiography will be the diagnostic method of choice. It shows the aneurysmal dilatation of the mesenteric and the renal vessels. Aneurysmal dilatation can occur in any one of these vasculitis because of weakening of the vessel wall, so it can occur in giant cell arteritis, in Takayasu arteritis, and polyarteritis nodosa. You remember Kawasaki disease from the previous discussions in the department. This is a very important form of vasculitis dominating over the other times, and you know that it affects the coronaries. 20% non-invasively can detect coronary aneurysms. It rises to 60% if we do coronary angiography. Obviously, we don't do coronary angiography in the acute phase, otherwise thrombosis will occur. We do it in the coronary in the chronic phase. These patients, they have the mucocutaneous affection, they have lymphadenopathy, they have fever, they have pulmonary erythema, and they have mouth ulcerations or injections. Berger's disease I will come to soon. This table is missing the microvascular vasculitis, which involves the small vessels. Essentially, they are classified into ANCA positive and ANCA negative vasculitis. ANCA is anti-cytoplasmic antibodies, and these are antibodies directed against two enzymes in the cytoplasm, proteinase 3 and the myeloperoxidase. The myeloperoxidase produce p-ANCA, paranuclear ANCA or perinuclear ANCA, and the proteinase 3 is producing a C or cytoplasmic ANCA. And this will help with the diagnosis of vaginal granulomatosis, Sjögren's syndrome, microscopic polyarteritis or polyangiitis, as well as vasoclastic cutaneous arteritis. So these are important subset of vascular diseases, particularly the large and the medium sized vessels. They have all of them are treated essentially by steroids and steroid-sparing agents. If they are permanent, then we use cyclophosphamide as an induction therapy and continuation by azacitidine and the new biologics, particularly anti-tumor necrosis factor antagonists like etanercept and infliximab. So Berger's disease, after the name of a New York pathology specialist, is common in male and female. You have to have heavy tobacco use, 1 to 3 packs or more a day. There is a triad of intermittent claudication, renal phenomena, and superficial thrombophlebitis involving the upper as well as the lower limbs, upper limb more than lower limb. And there is an abnormal Allen test, which we frequently use when we do a radial approach to cardiac catheterization. The Allen test, you compress the ulnar and the radial artery, they clench the fist to empty the vessels, and until the fist becomes pale, and then you remove the pressure from one artery. If the pulsations doesn't return, it means either this artery is occluded or the ulnar arch is occluded. Raynaud's disease and Raynaud's phenomena. The difference is that Raynaud's phenomena is secondary to certain conditions like collagen diseases, as well as drugs and thoracic inlet syndrome. And these are characterized, both of them are characterized by the occurrence of a triad in the large majority of cases of pallor, secondary to arteriolar constriction, cyanosis secondary to venous constriction, and rubor secondary to arterial and venous dilatation. And the difference between Raynaud's phenomena and Raynaud's disease is important. Raynaud's disease is usually a symmetrical condition, relatively benign condition, doesn't produce gangrene, while the opposite occurs in patients with Raynaud's phenomena. Question. A 73-year-old female smoker with primary history of cabbage with lima presenting for evaluation of recurrent exertional angina. Examination demonstrates a pulse delay between the right arm and left arm, as well as a left subclavian artery bruit. Referred for MRI of the upper chest, and we have the picture on the right side of the slide. Which of the following is the best next step? CT angiography, invasive angiography, duplex ultrasound, or transcranial Doppler. So obviously the diagnosis is established here by the MRI, and the next thing will be invasive angiography with the intention of revascularization by deploying a drug, a balloon expandable stent. We put a balloon expandable stent in this area so it doesn't jump like the self-expanding chest. If it jumps, then it might occlude the internal memory going downstairs, and more seriously, the vertebral artery going upstairs. So this is the knife, and this is exactly which has been done in this patient. As you see in this picture, very nice deployment of the balloon expandable large stent from via the left wrist, and the results are expected. We close by the ischemic stroke. Few comments about it. Transient ischemic attack, by definition, is a focal neurologic defect that lasts less than 24 hours. Usually it's less than 15 minutes, and very rarely it's more than 2 hours. And the definition of a stroke is a fixed neurologic defect. But the American Stroke Society defines a stroke now by an MRI definition, and that's a focal defect by diffusion-weighted MRI. So the stroke now is defined by an MRI imaging rather than by clinical. Obviously, you don't want the patient to progress to motor and sensory dysfunction with contralateral limbs, or pure sensory dysfunction, or isolated dysphagia, or transient monoocular blindness, which is amyloidosis with a few legs. If you get the patient having affection of the dominant hemisphere, he will be having aphasia, of course. He will be having Gerstmann syndrome, which is a combination of agraphia, finger agnosia, and disorientation. Here you will get spatial disorientation, unilateral neglect, and anosognosia, which is denial of the presence of paralysis. So you should be on the lookout for transient ischemic attack, because they have a bad outcome. Within 3 months, 10.5% of patients with transient ischemic attack, they get a stroke, and within 3 months, they get to 25% will get stroke, cardiovascular hospitalization, death, or recurrent transient ischemic attack. That's why we usually treat this patient as early as possible, best within the first 15 days of the transient ischemic attacks, 2 weeks from the transient ischemic attacks. And the standard line of treatment, if indicated, is usually carotid endarterectomy. It's not stenting. If there is a contraindication, carotid endarterectomy is not feasible, either because of anatomical reasons, like having a high carotid bifurcation for an infraclavicular carotid bifurcation, or there is previous neck irradiation, the hostile neck, or if the patient is having complete blockage of the other carotid on the other side, or if the patient is having any very calcified carotid artery, or if there is a physiological contraindication like advanced heart failure, left main, or more than 2 vessel disease, or the patient is frail and elderly. These are the indications is to move your direction towards stenting. So the standard line of treatment is carotid endarterectomy. With carotid endarterectomy, you don't get distal embolization. So dementia is an indication. And dementia is not an indication for stenting these patients because you clamp the internal carotid, you prevent any distal embolization. Whatever your embolic protection device is secure, you cannot prevent the distal embolization completely. So I stop at this stage and get any questions concerning this subject. محمد.
دكتور محمد انا مع حضرتك. اول سؤال بيسأل عن الجولد ستاندرد انفستيجيشن تو diagnose acute mesenteric ischemia.
Gold standard investigation for the diagnosis of acute and chronic is CT. Before CT was available, we were doing ultrasound. The problem is ultrasound is once you get paralysis of the intestine, you get a lot of collection of fluid and gas, and you get a poor picture. But the clinical picture is very persuasive. Severe sudden abdominal pain without guarding, without rebound, without rigidity, without any physical examination, fine. Directs your attention in an elderly individual or an individual who is young, who is having some sort of disease. For example, using contraceptive pills, using certain drugs which can enhance having antiphospholipid syndrome and so forth. Patients who are having an acute, who are present in acute medical conditions in the CCU, they are hypovolemic, they are shocked, they can get mesenteric thrombosis, which is present in the same way. CT is the ideal method for diagnosis. Usually we resort to surgery in the acute situation because of the fear of occurrence of intestinal gangrene, and there is some delay, and we use interventional procedures for chronic mesenteric ischemia.
اوكي هو لغايه دلوقتي ما فيش اي اسئله تانية في الشات.
طيب اوكي دلوقتي عندنا جالك حاجه؟
السؤال بيسأل management of coronary affection by vasculitis.
coronary affection by vasculitis إذا كان الكورونري affection هو الكومنست هو طبعا كواساكي. Kawasaki usually we treat early by intravenous immunoglobulin 1 gram per kilogram body weight acutely once. And then we put the patient on aspirin, maybe steroids, and anticoagulants if there is a large aneurysm more than 1 centimeter in diameter. So this is the common thing. Very rarely we resort to intervention like putting a coated stent graft. Other conditions they are usually microvascular because we don't get involvement of the coronaries in the except rarely in temporal arteritis or in Takayasu. So these are treated by steroids, and if they are aggressive, then we use cyclophosphamide for induction and continuation by methotrexate, mycophenolic acid, and the biologics like anti-tumor necrosis factor.
Okay. في سؤال بيسأل what is the difference between intermittent claudications and pseudoclaudications in peripheral vascular disease?
Pseudoclaudication is not peripheral vascular disease. Pseudoclaudication means something which is similar to claudication. These patients are having lumbar canal stenosis or a disc. فالعيان ده بيشتكي من ايه؟ بيشتكي اساسا من paresthesias. بس بما ان الtypical claudication في peripheral arterial disease is rare, only 15%, they can complain also of paresthesias. So paresthesias which occur when the patient is walking and also when he stands. العيان اللي عنده intermittent claudication يجيله البين او يجيله الكلوديكيشن او يجيله السيمبتومز ايا كانت when he is walking, but if he stands it disappears. That does not disappear when he stands. طب امال بتديسابير امتى؟ when he leans forward. when he leans forward تقدر الفورورد ليننج ده بيوسع اللمبر كانال، اللامبو سيكرال كانال. So as a result of that, the compression بتاع الكودا equina gets relieved. So the patient gets the symptoms, which is essentially paresthesias and pseudoclaudication, on walking, didn't disappear when he stands, but disappears when he leans forward. Then usually you need to order for this patient an MRI to identify the narrowing of the lumbar canal, and usually they are treated medically. This is different طبعا. In addition, peripheral arterial disease, you do the ankle brachial index, you find it abnormal. You do the pulsations, you find it abnormal. You do the imaging, you find it abnormal إلى آخره. لكن الجزء اللي خاص بالهيستوري هو ده الفرق بين الاثنين. العيانين اللي عندهم lumbar canal stenosis which is very common، تلاقيه وهو مثلا ماشي في السوبر ماركت، جار العربيه موطي عليها، leaning forward opens the lumbar canal, relieves الكلوديكيشن اللي هو موجود. لو ساب العربيه بقت miserable بالنسبه لي. اوكي.
في سؤال بيسأل why is ACE inhibitor is contraindicated in bilateral renal artery stenosis, however it's optional in unilateral renal artery stenosis.
ده هي is not optional، هي drug of choice in unilateral renal artery stenosis. and في bilateral renal artery stenosis نمرة واحد انك انت pathophysiology of hypertension here is not elevation of renin, but it is increased volume. But at the same time انك انت لما بتعمل renal artery stenosis you diminish الانتراجلوميرولار pressure. فالبودي كومبنسيت للحكايه دي بانه يعمل ايه؟ vasoconstriction of the efferent arteriole. لو انت عملت vasoconstriction of the efferent arteriole ترفع الانتراجلوميرولار بريشر وتحسن الجلوميرولار فلتريشن ريت. فده كومبنساتوري ميكانيزم mediated by renin. لما تيجي بقى تدي للعيان ده راس انهبيتور، سواء هو renin angiotensin inhibitors او ACE انهبيتور يعني، او اربس او رينين انتاجونست السكايرين، هتفك الفازوكونستريكشن اللي موجود في الافرنت ارتريول اوف ذا كدني. So as a result of that the glomerular filtration rate هيبطأ في التو kidneys. As a result of that acute renal failure will develop. So if you give the patient with bilateral renal artery stenosis an ACE or an ARBS or a renin inhibitor, he will pass into acute renal failure because you are diminishing the glomerular filtration rate, because you are undoing the vasoconstriction in the efferent glomerular arteriole on both sides. Okay.
اوكي يا دكتور حمد، ما فيش اسئله تاني.
Okay. We have two lectures الجمعة الجاية والجمعة اللي بعدها. Two lectures دول very important. Every cardiologist on earth is being asked to participate in them because هما الريفيرالز اللي بيجي لنا pregnancy and non-cardiac surgery. مفيش واحد مننا ما بيجيلوش أسئلة هنعمل إيه في العيان اللي داخل يعمل كوليسيستكتومي ولا هيعمل peripheral vascular disease إلى آخره، أو this pregnant woman which is having so and so of cardiovascular disease. So let's wait for next and the Friday after the next. Okay, thank you very much. وتصبحوا على خير.
شكرا دكتور محمد، وكل سنة وحضرتك طيب.
طيب يا ست الكل.
مع ألف سلامة بيه.